Hello, and welcome to CAH Cost Report Geek, your resource for the Critical Access Hospital Medicare Cost Report. Today's discussion is CAH charges to cost settlement and includes Medicare Beneficiary Coinsurance and the impact of a price increase on the annual impact for an outpatient cost center. This special topic is part of a request from Lindsay, one of our loyal subscribers. Our discussion is brought to you from Conference Room G in our office in Nashville, Tennessee. Our agenda includes an overview of the CAH payment methodology, the interim rate letter, Medicare Beneficiary Coinsurance, inpatient and swing bed charges and payments, including coinsurance and the cost settlement, and outpatient charges and payments, including coinsurance and the cost settlement, as well as the impact and observations of increasing the chargemaster. Well, shall we begin? Let's get dialed in here and let's get started. Let's start with an overview of the CAH payment methodology. CAHs are reimbursed based on allowable costs for treating Medicare patients for inpatient, swing bed, and outpatient services and are paid at 101% of costs less 2% sequestration. It's important to note here that this system is fundamentally different than hospitals reimbursed under the prospective payment system. To be clear, CAHs are not subject to the inpatient prospective payment system or the outpatient prospective payment system. Cost is estimated using cost accounting data from the Medicare cost report. Charges and payments are added to the formula to derive at a cost settlement. Medicare Part A and Part B have separate deductible amounts, and beneficiaries are subject to coinsurance obligations. Please note that Part B charges are not limited by the Part A inpatient deductible amount. The interim rate letter is a written communication from the hospital's Medicare administrative contractor and is issued after a hospital files a cost report, an interim cost report, when a hospital requests an interim rate review, and in other circumstances. Rate letters provide updated payment rates for inpatient per diem rates, swing bed unit per diem rates, and the outpatient interim payment rate expressed in the form of a percentage. By per diem rate, we mean a rate of payment per patient day. The example below shows the basic contents of payment rates in the rate letter. Next, we will discuss coinsurance of CAH Medicare beneficiaries. The coinsurance amount is equal to 20% of gross charges billed to Medicare. Please note that gross charges are often priced higher than expected payment rates. There is currently no limit on the coinsurance amount for CAHs. Conversely, the prospective payment system limits hospital coinsurance to 20% of the Medicare payment rate. Now let's walk through an example of charges, coinsurance, and settlement for an inpatient or swing bed unit. Both are paid at a daily per diem rate, and the costs are calculated on the cost per day, so the steps in this scenario would be the same for both services. We combine the allowable direct cost with the allocated overhead cost to arrive at the total allowable cost. We then divide this amount by the number of patient days to determine the actual cost per day, which in this case equals $2,860. We multiply this daily cost by the number of Medicare days to determine the total reimbursement from Medicare, which is just a little over $2.5 million. In this scenario, Medicare charges were $2,500 per day for a total of $2.2 million. The Medicare coinsurance amount is $440,000, which is 20% of Medicare charges. This amount, along with the amount of interim payments received, is deducted from the total Medicare reimbursement to determine the settlement. Since the coinsurance and interim payments received are less than the total Medicare reimbursement, the resulting difference is a settlement due from the Medicare program. An important observation is that the hospital was billing $2,500 per patient day and this was significantly less than their actual cost per day. An interim cost report would have identified this, and its filing would likely have increased the hospital's per diem rate, therefore increasing the interim payments received. Now let's shift gears to look at the charges, coinsurance, and settlement for an outpatient cost center. The total allowable cost, consisting of direct and allocated costs, equals about $1.6 million for this cost center. We divide this by the total charges of $3.5 million to calculate the cost to charge ratio of 46%. We multiply this by the Medicare charges to arrive at the Medicare cost of about $880,000. The Medicare Beneficiary Coinsurance obligation is 20% of the Medicare charges, or $385,000 in this scenario. The sum of the coinsurance obligation and the interim payments received in this scenario exceed the Medicare cost, resulting in a payable to Medicare caused by this cost center. The interim payments received from Medicare would be Medicare charges multiplied by the Part B interim rate percentage less the coinsurance obligation. Given equal charges, a higher interim rate results in higher interim payments, while a lower interim rate results in lower interim payments. This is why it's so important for a hospital to know and understand its current payment rates. Let's further examine the outpatient cost center scenario, only this time we'll introduce a 20% price increase in this cost center only. All things equal, the increased charges would increase the interim payments received. This is true in our example, as we collect $614,000 in interim payments compared to the $512,000 in interim payments received without the 20% price increase. What else do you notice? The coinsurance, 20% of gross charges, increased to $462,000 from $385,000 due to the price increase. Does anything else stand out here? What about the Medicare cost? They are the same in each scenario. The price change results in an increase in interim payments and coinsurance. In other words, it impacts the components of cash flow, but the overall annual impact of the outpatient cost center remains unchanged. Why is that? Let's refer back to the CAH payment methodology slide and recall that CAHs are reimbursed based on allowable costs for treating Medicare patients for inpatient, swing bed, and outpatient services. No change in allowable costs results in no change in total reimbursement. Now, to be fair, some hospitals do allocate some costs based on gross charges. As a result, the overhead allocations will change when a price increase is made, so this could potentially increase the annual impact of one cost center, but note that this can be offset by decreases in annual impact in other cost centers due to the change in overhead allocations. We will wrap up here today by saying that fundamentally, we view the setting of charges as a strategic decision, but setting charges to cover direct costs of a cost center is a prudent and logical choice. Remember that coinsurance is based off of charges for CAHs. Increasing or decreasing charges does not directly impact the annual impact of a cost center, but does impact the cash flow. Keeping up to date with payment rates set by the Medicare administrative contractor is critical, as this information is of strategic use in pricing of charges. To request content on a topic, please send us an email to CAHcostreportgeek@gmail.com. Thank you for joining us, and we look forward to serving the CAH community with you.